SOHO 2024 with Dr. Hagop Kantarjian, my department chair. And Dr. Kantarjian has been involved in the development of new drugs for CML for the last several decades. And here we are going to have him talk about his view of the development of CML strategies in the last 2 decades especially, and then how he views the field moving forward. Dr. Kantarjian?
Thank you, Nitin. So as some people know, I started my career in 1980. And in 1980, in chronic myeloid leukemia, the only 2 drugs that were available were busulfan and hydroxyurea. The average survival in these patients was 3 years. Most of the patients were dead by 10 years from diagnosis. And the only curative therapy was with the budding and emerging field of allogeneic transplant, where if you had a patient with chronic myeloid leukemia in chronic phase diagnosed, if you took them to an allogeneic transplant, the potential cure rate was 40%. The first endeavors were with interferon therapy in chronic myeloid leukemia, and that research started with Dr. Moshe Talpaz at our institution, and I joined him in that research. And what we found is that interferon therapy achieved several purposes. The first one is it induced suppression of the Philadelphia positive CML cells, which we thought were causal to chronic myeloid leukemia. It prolonged the survival from 3 to about 7 years. But we saw that the patients had serious toxicities with interferon therapy. We later tried to develop additional agents like homoharringtonine, low-dose Ara-C added to the interferon therapy. And this brings us to about 2000, at which time some of the preclinical studies had established a causal association between the Philadelphia BCR-ABL molecular events and the development of CML. So this was an important finding because prior to those animal experiments, the impression in the clinic was that the Philadelphia event, the Philadelphia abnormality was a late event, and if we suppress the Philadelphia positive cells, we were not going to improve the survival. So researchers introduced the BCR-ABL abnormality into the genome of mice, into the genome of hematopoietic cells in mice, and they saw that those mice developed chronic myeloid leukemia. So they recapitulated the human pathophysiology, demonstrating clearly that there is a causal association between the Philadelphia BCR-ABL molecular events and the development of CML. So this is what energized investigators to develop, create, and identify BCR-ABL inhibitors. So this work was led by Dr. Brian Drucker, and in 2000 we were ready for the first large-scale clinical trials looking at the first BCR-ABL inhibitor, imatinib, which is known commercially as Gleevec. 2000 was the really turning point in CML research, because what we found is that when we gave imatinib to patients with chronic phase chronic myeloid leukemia, we induced suppression of the Philadelphia chromosomal abnormality and the BCR-ABL events below 1% in over 90% of the patients. And now the patients were not dying anymore at a rate of 25% per year. Actually, the annual mortality went down to 1% or less. So with the follow-up of about 10 to 20 years, we saw that patients with chronic myeloid leukemia on imatinib therapy were living almost a normal life. The annual mortality related to CML went down to less than 0.5 to 1% per year. So this was a big breakthrough. But then, because the leukemia cells are smart, we found that they started developing mutations at the attachment site of imatinib at the ABL kinase domain. So then researchers developed what is called the second generation BCR-ABL TKIs, including dasatinib, nilotinib, and bosutinib. And we found that those second generation newer TKIs were able to overcome the resistance of the imatinib-induced mutations. and were able to, again, prolong the survival of the patients. There was one particular mutation called T315I, which was resistant not only to imatinib, but also to the second generation TKI. And this is where several companies now have developed third generation TKIs, including ponatinib, as well as asciminib. And there are newer ones like olverembatinib and from two other companies. And these are what's called third generation TKIs that suppress the T315I mutation. Now, ponatinib, the first third generation TKI, had significant toxicities, and it found a home in Philadelphia positive ALL. And we refined the research to reduce the toxicity by reducing the dose schedule. At that point in time, some companies started developing what is called selective targeters of the ABL myristoyl pocket, or what is called STAMP inhibitors. So one of them is asciminib. There are several others which are coming along, but the olverembatinib drug from China is actually more similar to ponatinib in the sense that it targets the ABL kinase domain mutation rather than the myristoyl site. So now with the third generation TKIs, we are at the cusp of real breakthroughs in terms of not only normalizing the survival in CML, but also inducing durable, deep molecular responses. So if we can suppress the molecular abnormality to a level of less than 1 in 10,000 for a period of 5 years, we know from the existing data that we can stop the TKI therapy, and 85% of the patients will never or will not have relapse of the chronic myeloid leukemia. So essentially, a treatment-free remission, which I like to call a molecular cure in CML, but other CML experts are a bit wary to introduce the term cure in that setting. But I'm very comfortable to say that with the current tools that we have today, we can probably cure over 60 to 70% of patients with CML. Now, what about the future? I think we're going to try to combine the BCR-ABL kinase inhibitors with other agents, but we have not been successful so far. We will try to develop more potent BCR-ABL kinase inhibitors that do not have the toxicity of ponatinib. So this is where asciminib or olverembatinib or the new STAMP inhibitors may have a role. And we would like to perhaps consider immune strategies that could enhance the potential cure rate in chronic myeloid leukemia. So before 2000, when I saw a patient with CML, I told them the dim prognosis. I told them that the average survival was going to be 3 to 6 years, that they needed to go to an allogeneic transplant. Today, when I see a patient with chronic myeloid leukemia, I tell them that the outcome is going to be wonderful, that most of the patients will live their near normal life, and many of them will be cured and can stop TKI therapy and live again a normal life.
Thank you, Dr. Kantarjian. This was a fascinating history and how the development of ABL kinase TKIs have really changed the paradigm of CML management, and I think majority of patients now approaching cure with this disease. Thank you.